Abnormal uterine bleeding. Abnormal uterine bleeding is irregular uterine bleeding that occurs in the absence of recognizable pelvic pathology, general medical disease, or pregnancy. It reflects a disruption in the normal cyclic pattern of ovulatory hormonal stimulation to the endometrial lining. The bleeding is unpredictable in many ways. It may be excessively heavy or light and may be prolonged, frequent, or random. Abnormal uterine bleeding is a common diagnosis, making up 5 to 10% of cases in the outpatient clinic setting. Because most cases are associated with an ovulatory menstrual cycles, adolescents and perimenopausal women are particularly vulnerable. About 20% of affected individuals are in the adolescent age group, and 50% of affected individuals are aged 40-50 years. Patients with abnormal uterine bleeding have lost cyclic endometrial stimulation that arises from the ovulatory cycle. As a result, these patients have constant, non-cycling estrogen levels that stimulate endometrial growth. Proliferation without periodic shedding causes the endometrium to outgrow its blood supply. The tissue breaks down and sloughs from the uterus. Subsequent healing of the endometrium is irregular and asynchronous. Chronic stimulation by low levels of estrogen will result in infrequent, light orb. Chronic stimulation from higher levels of estrogen will lead to episodes of frequent, heavy bleeding. The physical examination can elicit several anatomic and organic causes of abnormal uterine bleeding. A complete physical examination should begin with assessment of hemodynamic stability, vital signs, and proceed with evaluation of the following: obesity, signs of androgen excess, hirsutism, acne, thyroid enlargement or manifestations of hyperthyroidism or hypothyroidism, galactorrhea that may suggest hyperprolactinemia. Presence of visual field deficits should raise suspicion of intracranial or pituitary lesion. Ecchymosis, purpura may indicate signs of bleeding disorder. Signs of anemia or chronic blood loss. A careful gynecologic examination, including Papa-Nicolau test and sexually transmitted disease screening, is warranted. The hallmark of abnormal uterine bleeding is a negative pelvic examination despite the clinical history. In such cases, management might rest on a clinical diagnosis, rule out the presence of uterine fibroids or polyps, as well as rule out endometrial hyperplasia or carcinoma. For diagnosis, studies used to exclude a pathologic source of anovulatory bleeding include the following: human chorionic gonadotropin, complete blood count, Papa-Nicolau test, endometrial sampling, thyroid functions and prolactin, liver functions, coagulation studies or factors, and other hormone assays, as indicated. In obese patients with a suboptimal pelvic examination or in patients with suspected ovarian or uterine pathology, pelvic ultrasonographic evaluation may be helpful. Ultrasonography can be used to identify uterine fibroids, as well as endometrial conditions, including hyperplasia, carcinoma, and polyps. Hysteroscopy and MRI may be advised as indicated. Endometrial sampling by endometrial aspiration or dilation and curettage to rule out endometrial carcinoma in all patients at high risk for the condition, including those with the following characteristics: morbid obesity, diabetes or chronic hypertension, age over 35 years, long-standing, chronic gonadal anovulation. Most endometrial biopsy specimens will show proliferative or desynchronous endometrium on histology. Surgery should be considered only in patients in whom medical treatment has failed, cannot be tolerated, or is contraindicated. Endometrial ablation is not acceptable as a primary therapy, because the procedure can hamper the later use of other common methods for monitoring the endometrium. Regardless of patient age, Progestin therapy with the levonorgestrel intrauterine device should be considered. Contraceptives containing a combination of estrogen and progesterone also provide effective treatment. Low-dose combination hormonal contraceptive therapy, 20 to 35 microgram ethinyl estradiol, is the mainstay of treatment for adolescents up to age 18 years. Either low-dose combination hormonal contraceptive on treatment or progestin therapy is generally effective in women aged 19 to 39 years. High-dose estrogen therapy may benefit patients with an extremely heavy menstrual flow or hemodynamic instability. Medical treatment for women aged 40 years or older can, prior to menopause, consist of cyclic progestin therapy, low-dose oral contraceptive pills, the levonorgestrel intrauterine device, or cyclic hormone therapy. If medical therapy fails, patients should undergo further testing. An in-office endometrial biopsy is preferable to dilation and curettage when examining a patient for endometrial hyperplasia or cancer. If medical therapy fails in a woman in whom childbearing is complete, hysterectomy without cervical preservation may be considered. Pharmacologic treatment: oral contraceptives to help suppress endometrial development, re-establish predictable bleeding patterns, decrease menstrual flow, and lower the risk of iron deficiency anemia. Prolonged uterine bleeding suggests the epithelial lining of the cavity has become denuded over time. Estrogen administered alone will rapidly induce a return to normal endometrial growth. Chronic management of abnormal uterine bleeding requires episodic or continuous exposure to a progestin, a synthetic analog of arginine and vasopressin. Desmopressin has been used as a last resort to treat abnormal uterine bleeding in patients with documented coagulation disorders. Abdominal or vaginal hysterectomy may be necessary in patients who have failed or declined hormonal therapy, who have symptomatic anemia, and who are experiencing a disruption in their quality of life from persistent, unscheduled bleeding. Single episodes of anovulatory bleeding generally carry a good prognosis. Patients who experience repetitive episodes might experience significant consequences. Frequent uterine bleeding will increase the risk for iron deficiency anemia. Flow can be copious enough to require hospitalization for fluid management, transfusion, or intravenous hormone therapy. Chronic unopposed estrogenic stimulation of the endometrial lining increases the risk of both endometrial hyperplasia and endometrial carcinoma. Timely and appropriate management will prevent most of these problems. Many individuals with abnormal uterine bleeding are exposed to unnecessary surgical intervention, such as repeated uterine curettage, endometrial ablative therapy, or hysterectomy, before adequate workup and a trial of medical therapy can be completed. Iron deficiency anemia. Persistent menstrual disturbances might lead to chronic iron loss in up to 30% of cases. Endometrial adenocarcinoma. About 1 to 2% of women with improperly managed anovulatory bleeding eventually might develop endometrial cancer. Infertility associated with chronic anovulation, with or without excess androgen production, is frequently seen in these patients. Patients with polycystic ovarian syndrome, obesity, chronic hypertension, and insulin-resistant diabetes mellitus particularly are at risk.